Wait, what?
Alright, 1 hour left, guys.
That was a long drive, man.
I think I like slept, not like too much over the break, that's why my body is not used to being awake so much.
This is a hard.
In a row.
Like, I was like looking at the schedule, like, oh, now I'm gonna be up at 6 to 7 and 8 every morning, like, most of the week now.
Yeah.
I was like, no.
Yeah, I was thinking
At the end of class to double check, so I'll make
I was completely nocturnal. I switched like so entirely.
All right, so body of mechanics, so there's a couple of slides on body mechanics. I'm not gonna go through every single one, but you wanna make sure that you're aware of the importance of body mechanics because our field is very physical. In regards to our patient and our patient movement and the various positions we have to put them in and just moving them from one area to another. So you wanna be mindful of the proper ways of moving patients. Ultimately, you have to put the patient at their safety at the presence or primary aspect of every move, whether it's a wheelchair move, a stretcher move. You want to make sure that everything is safe for that patient. Also, really important in our profession is to get help. Okay, if you're not able to safely move a patient on your own, or that patient might be a larger individual to where you're going to need help, get the help. Don't try to make a patient move or move a patient on your own because you're risking yourself potentially getting injured or getting hurt. We had two main areas that we focused on when we were going through this information. The base of support, so we talked about having that shoulder width stance is going to give you a better base of support as opposed to keeping your feet real close together. So you want to have that wide stance, shoulder width apart, to give yourself that support that you need. Also, the center of gravity, okay? So you want to keep everything in that same alignment and focus on your center of gravity, which is in your pelvic region. Like what number?
27.
Mm-hmm. Yeah, I'm kind of like skipping some. I'm not going like in order.
No, the last slide you had, it wasn't, I didn't have it.
Oh, that one was 24. This one's 24. Was it this one?
Oh, no, they told me it's the same.
I think
It's
it's
just a different.
Yeah, some features changed, but.
Oh, okay. So be mindful of your center of gravity. The last thing for good patient movement is a proper way to lift, okay? So remember, we're going to be lifting with our legs, okay? You never want to lift with your back. So you want to make sure that you have your proper stance, your base of support, focusing over your center of gravity and making sure that you're lifting with your legs, okay? We don't want any potential back injuries. You don't want to overreach. Try to keep everything in that alignment over your center of gravity. And again, make sure you're asking for help. Also, ask the patient what they can do. If you have a patient coming to you on a stretcher, just don't assume that they're immobile or they can't do anything. You know, the first thing I always ask my patient is, I'm going to need you to stand up for this x-ray, I need you to come over to this floor. Okay? And then I let them tell me what they can and can't do. All right? Or you might have a patient where the nurse communicates to you, hey, this patient can't get up, or this patient is limited, or I just gave this patient pain medicine, so they may be a little bit woozy. So then you want to take a different approach. But always get the patient involved as well, because they may be able to assist, or they may be able to help with the movement too, and then that's less strain on your body.
You're trying to kill me. But it's like, look my leg.
have been laying down, or, you know, you guys have encountered patients that come to you in their hospital beds, right? So if they come to you in the hospital bed, you know that patient hasn't really been moving, because obviously there's a accountability issue. So what's that term that we use for a patient that may have been laying down or seated position for a really long time, they get up, and then they have gotten up too quickly, and now they're kind of.
Orthostatic.
I love it.
Correct.
Which one?
Oh, look at y'all remembering.
Which one is it?
Sorry. Orthostatic hypotension. I'm gonna put it up now. All right. So that's where you have a patient. They may have been laying down for a long time. They get up all of a sudden, and you're gonna start to see very symptoms sometimes occur, and that term is known as orthostatic hypotension. So you want to be careful of that, because the patient could potentially fall or pass out on you if they're going through this process. So make sure if you have a patient that's coming to you in their hospital bed or even a stretcher, I always like them, if you're going to have them stand, I always like them to sit up on their stretcher for a few minutes before they actually get up to stand. All right? Remember the process of moving or transferring a patient from the wheelchair to the table. You want to make sure that you're putting that wheelchair at a 45 degree, especially if it's a one-person assisted movement or transfer. That wheelchair should be locked at 45 degrees, and then you're going to have the patient stand up, pivot, sit on the table, and you're going to assist them to lay down. If it's a two-person lift, this is where you have the patient is going to be, the wheelchair will be parallel to your table that you're moving them on, and you have one individual behind them, one in front assisting with their legs, okay? How many of you guys have had the opportunity to use some of the larger equipment for patients that are completely immobile, like the actual lifts? So Lauren has,
I saw the VA,
you saw it at the VA?
but they have like their own team to do it. We're not allowed to do it.
Oh, okay, okay. So a lot of the larger hospitals will have those equipments to where they can lift patients that are just completely immobile or larger patients. But a lot of times they just don't like to do it, just because it's usually just kind of tucked in a storage room somewhere and nobody ever uses it. But larger hospitals should have that equipment to assist with those patients that are completely immobile if you need to. We also got the cookie sheets and the slider sheets, which are great for that lateral transfer from stretcher or hospital bed to table, which is really resourceful. What about backboards? What are some things that you want to keep in mind when moving a patient that's on a backboard?
Make sure that you, if they're seat collars on, that you're going to hold that and transfer.
Right, so making sure their neck is stable if they have a C-collar on, because if a patient is on a backboard, what's the reason they're on the backboard? Can we just take them off?
No.
Correct, so we cannot remove a patient from a backboard, because they are on that backboard or they have that collar on because of a potential spinal injury. So we are not able to remove that individual from the backboard. Only the doctor can make that determination.
We had a patient, well, this is not in reality, but we had a patient that was on the backboard that I was taking care of. And when I tell you, everything had to be done with that backboard, and Ellie died on it.
Was that at Maine?
It wasn't at, it was at where I work at.
Oh.
I was like, why is this backboard still here? I mean, she came into the ER and never came out. Like,
Yeah, so with the backboards, we have to, do our exams. A lot of times they're gonna come to us because that's one of the ways that the physician can clear them from the backboard. We wanna see those initial x-rays to make sure there's no injuries to their spine. So we do the x-rays with them on that backboard. And sometimes unfortunately, and I don't know if some of you guys have had this experience, they may want repeat x-rays after they're off of the backboard. So it's like kind of like, oh, you're back again, okay. So you might go through that as well. But we are not able to remove a collar, and we're not able to move individuals from the backboard. We have to keep them on there. So with the backboards, you wanna, again, all of the backboards typically have those little circular handles on the edges. So you can, use that to assist in moving the patient over to your x-ray table. You also wanna document to the radiologist that the patient was on a backboard, because we know, we're gonna see some images from the backboard overlying on our image. What is that gonna be called?
Radio.
Correct, but what else?
Artifact.
Artifact. Yeah, so you wanna communicate to the radiologist, hey, there's gonna be foreign object artifacts because the patient was on a backboard, so they know what's going on. And they're just not like, why is this here? What is going on? What are you doing? How many of you guys have had direct interactions with radiologists? So how'd that go?
They're nice.
Yeah.
So far they're nice.
Right.
Very dry.
Okay. All right. So just communicating to the radiologist what's going on with those backboard patients.
Sorry, I do have a quick question,
Uh-huh.
because I did run into this. Say a patient has a C-collar, but hasn't been clear, so they haven't taken it off, they need to do a portable chest x-ray. Would you still hold it, or would you tell the patient to lean forward so you can do it?
We have to
No,
get
we'll move the patient forward to put the board behind their back, because the collar is there to immobilize and stabilize
Okay,
their
and I
neck.
wasn't
So
sure, because I saw them doing it, but I was like, I thought we always had to get somebody to hold the
Yeah.
C-collar. So for a chest x-ray, they're still able to,
Mhm.
you're allowed them to move forward?
Mhm.
Okay.
Now, if they're on a whole backboard, you
No,
can.
they were already sat up, it's just they had
Oh,
the
yeah.
C-collar on. and
Yeah,
I was
you
just
can.
like, Okay.
So now we're gonna review some of our vitals. Well, before we get into vitals, we'll spend some time looking at equipment. So there was various equipments that we talked about in this class. One of them is oxygen, also known as O2. So there's various forms of ways that the oxygen can be administered to patients. Are we able to put a patient on oxygen?
No.
So what's needed for a patient to be on oxygen?
Doctor.
So it has to have, you have to have a doctor's order, all right? And we can't change that. So if a patient comes down to us and they're like on 5 liters of oxygen and they're like really short of breath and they're having a hard time breathing and they're gasping, we can't just up it to 10 because we feel like they need it. You have to have a doctor's order. So it's important when patients come to you and they are on oxygen, you look at what liters they're on, because you need to have that same liter amount when you connect them to your wall oxygen. Usually when patients come to us and they're on oxygen, we connect them to the wall unit in our x-ray room, so we're not wasting that oxygen in their portable tank, because we want to make sure they have enough oxygen in that portable tank to get back to the floor. So one way of administering oxygen is what you see here. This is pretty much the common one, the nasal cannula. All right, so you want to make sure that you're careful with that. A lot of times it gets moved around when we're moving the patients for exam. So if it gets moved and the actual cannula isn't in the patient's nose, you may want to just fix it for them before you leave. We also have the O2 masks, okay, where the patient has a whole mask over their mouth and nose region that's on their face, so you might see that. You might have a rebreather that has the bag attached to it, okay? So there's various types of oxygen administration. We also have airway intubation that we might see on some of our more critical patients, all right, where they have ET tube placed. And we know that we're always involved for the ET tube placements, because what are we gonna do?
Make sure they in the correct spot.
Say that again?
We gonna x-ray them, but make sure they in the correct spot.
Mm-hmm. Yep, so they're gonna want that chest x-ray to confirm placement of the ET tube placement. to make sure it is in the correct region. So usually they're gonna count down to the vertebral body to see if it's where it needs to be. Right? Sometimes they don't quite get it right on the first attempt, and they may have to either advance the ET tube or pull back on it, and we gotta do another chest x-ray. All right? So just being careful and mindful of these placements. Now, are we able to put in an ET tube? No, so that is not in our scope of practice. We definitely did not provide y'all any training on that. So, not in our scope of practice. That's going to be your physicians or even respiratory therapists, but we do not do ET2 placements. All right. Another trachea equipment that you'll be familiar with, and I'm sure you guys have interacted with patients as well, is a tracheostomy. So this is different than an ET2 placement. You're still having a device placed in the trachea region of the individual, but it's more of an external device, okay, that is through the patient's neck, and they have, usually they're going to be connected to oxygen there most times, all right? And we know that these different equipment and patient tools that we're talking about can be on all patients. So we see even on the little ones, right, that they are on oxygen, they have tube placements just like the adults. So when we go and do those exams, portable in the NICU, we want to be careful with the little ones and get the assistance from the nurses as needed to move the patients or move the babies into the certain specific positions that we need them to be in. What about suction? What is that for?
You suction out the blood, the mucus, and all of that from the tracheostomies and stuff like that.
Yeah, so it's used for a variety of reasons, but mainly it sucks. You know, it sucks fluid, secretions, either from the patient's stomach region. Sometimes we have patients have MBCs or MB2s, and it's connected to suction to get extra secretions out of that stomach region. Sometimes we use it if we think a patient may have aspirated. They'll go in and do a quick suction to try to get whatever that patient aspirated on. So again, this is not in our scope of practice. We don't suction individuals or place them on suction, but you do want to be aware of it and what it's for. Just like we have wall hookups for O2, typically suction is going to be right there next to our oxygen hookups in all of our x-ray rooms if a patient should need to have this utilized. We've got urinary catheters, so again, we don't place that. Thank goodness they don't need an x-ray to confirm this because we would be really busy. But urinary catheters you just want to be mindful of. So, or so when you're doing portables or patients are coming down to you, you don't forget to move that catheter with the patient. You don't want to be pulling out a patient's catheter. But this is something that the nurses will place in patients. What type of exam do we do that we will have to put in a catheter? Well, not us, but the nurse will have to put in a catheter. Not for
The bit
urinary,
in the catheter.
but specifically for the urinary.
The IVU?
Mm-mm.
Retrograde, the retrograde,
Yeah.
cystography.
Mhm.
Retrograde now.
Yeah, so the retrograde, which is going against the flow, they're going to put a catheter in so we can administer the contrast that route. Also, the voiding cystograms, okay? Patients that have to do the voiding cystograms, typically they're going to put a catheter in. We'll administer the contrast media. When we're done with all of our images, we're going to take the catheter out and then allow that patient to void. Well, but it's not urinary.
Okay.
Yeah, so we do use catheters for VE, but not urinary. So, but those we do put in.
Yes.
Yes. How many of you guys, I was meaning to ask this when we were talking about the backboards, how many of you guys need cross table spines? Ooh. All right. So cross table spines, cross table hips, sometimes ribs are usually like, we find seniors still need at this point. So if you haven't seen it up to now, it's not, you know, something that's regularly seen, especially the cross table stuff. So you may need to ask wherever you are. If a patient comes in for like a lumbar spine, you may want to ask your tech, hey, I need a cross table spine comp. Can I do that on this patient?
I've asked them now 3 sites and they say no.
What are the sites so we know not to ask?
It gonna depend on the tape too.
Yeah. Union said no, what was the place I'm looking for that? Yeah, they basically said unless it's ordered like that, that they couldn't do it. And then I tried, they let me try I did do it at Noonan, like post-surgery, but because like it was like a cervical thing and you couldn't see 7, they didn't like check me off on it. So I did it, but they wouldn't check me off because you couldn't see 7 on it. And
Okay.
then there was 2 other places. One of them was the outpatient, and I can't remember what the other place was. But basically, they said unless it's not ordered like that, you can't just do it.
What about the VA? No.
Because the tech got rocked to like he could cross table spine because the lady wasn't comfortable doing a lateral, turning lateral like his ass. And I'm like, she's uncomfortable laterally. He said, maybe because he was a traveler, he just let me do it.
So if you guys are still not seeing them, since there's quite a bit of you that need that, I would say by like within the next month, by February, if you still haven't come across it, let us know because we can simulate it on campus. So that way we could like strategically plan to start simulating those with you because we know you're only here 1 day a week.
I still need a skull. They don't happen in most of the sites I've been at recently, and they've already told neurosurgeons that they can never see skull.
Okay. So like pretty much any,
Skulls are elective, right?
Yeah.
you have to have one.
You have to do one.
You have to do one like either facial bone, sinus, something in that
So
head
mandible
region.
counts under that.
Yeah,
I believe
it
so,
does.
and TMJs, yeah.
Because yesterday I did a sinus.
I've barely done any skull.
Yeah, so for sure, like start communicating with me stuff that you're still missing because basically by the end of the semester you need that whole list checked off. All of your competencies need to be done. Yeah, you can simulate. Obviously, we prefer for you guys to do it in the clinical sites. That's why I was saying, like, give it a month. If you're still not seeing stuff, start communicating, like, what your needs are so we could strategically schedule you guys to simulate. Not because you can't simulate everything, so we do want you guys to try to get it done in the clinical sites, but we know that some things you may not see at this point, and it's the last semester. The things that you absolutely can't simulate is fluoro exams and surgery, because we just don't have the means of simulating it here. Yeah. How many of you guys are in that situation where you need fluoro surgery? But you're at that site now, right? Okay. All right. So yeah, so just at the beginning of February, just start communicating to myself and Ms. Wallace what your needs are, so we can either have you come in a little early or stay a little bit late to do those simulations. All right. We also, not only do we see a lot of catheter placements, but a lot of IV and line placements, right? So those typically involve x-rays and require us to come, whether it's a central line being put in, an abdominal line that's being inserted through the femoral artery. They're going to want to confirm placement, and we're either going to have to come and do a chest or abdomen x-ray. So just be careful with those lines, especially the CVP lines, the central venous placement lines, because those are like minimally invasively put, and you don't want to disrupt or dislodge any line placement. So be careful when you're moving patients. Typically, a lot of our unit patients are gonna have those lines placed, so if you're moving them to get the receptor behind their back for the chest x-ray, you wanna not make sure you've got enough slack on those lines, so when you bring the patient forward, nothing is getting pulled.
Quick question with that, because this one tech was talking to me about like ECMO. Have you ever had to do any x-rays on an ECMO patient before? Cause that looks terrifying.
They do
ECMO?
that a lot. At Eggleston, they do
Yes, so
that.
it's basically like this gigantic dialysis type machine that takes all your blood and filters it for you.
It's like an outside heart.
Yeah, like an iron lung
They're
for your
really
blood.
finicky.
It's really
Like, usually doctors and nurses are all around those patients and you have to like squeeze in and they'll help usually, cause, you know, keeping the patient calm.
Yeah, and I Googled it and I was like, I don't know if I would ever do an x-ray on that because it terrifies me.
No, I haven't.
I might just pass that one on to somebody else. It's so intimidating. Like, literally all their blood is like right there next to them. Like, how cheap is like one even move that patient in this chest? And they're still on a wait.
And do they have them like on a bed to where there's a tray underneath? Because sometimes patients that are like that, unstable, like they don't want to move, they'll like have special beds they'll put them on to where
Sometimes they do.
there's like a tray under the bed.
They were telling me that like some of they cost, I think they said like North Fulton or something like that, like north side of the I've come across.
No, but sometimes, but I mean, I've had to do exams on patients where they just basically don't want you to move with like any type of movement, throw their blood pressure off, and get crash and stuff like that. But sometimes what we do to try to minimize like actually physically moving the patient is like try to slide it under the sheet.
And then the bed, some of the beds have,
They have like special zippers that.
yeah, the little zippers, and
Yeah,
you can slide that.
Yeah.
So the ICU
Well,
beds.
this is like,
All right, so we also, when we encounter our pacemakers, and not only do we do chest x-rays on pacemaker, for our pacemakers, when, you know, sometimes they're just confirming the site, especially if a patient just had a pacemaker put in, they're always gonna have a chest x-ray post-op just to make sure that the pacemaker is positioned where it needs to be, the leads are positioned where it needs to be. Also, during the actual, placement of the pacemaker, when the patient's in surgery, we're there with the C-arm too. How many of you guys have been involved in those type of cases? Any pacemaker C-arms? No?
Any what now?
I've seen reports.
C-arm,
Yeah, I've seen
surgery
reports.
cases with the pacemaker being inputted. So we're there with the C-arm to, make sure that the cardiologist is putting the pacemaker and the leads and everything is going where it needs to. Chest tubes is another equipment that we see quite commonly with our patient population. So where do we say, with the patients that are having chest tubes, usually these are the main reasons why you might see patients having chest tubes. And again, we'll see that on our pediatric population as well. Where should those chest tubes be placed? What's the rule of thumb?
It's like going, is that the?
On the
Is it
floor?
the collection?
What you mean where they should be placed? Like
They on
inside the
the
person?
floor.
It's
On
always,
that side?
it's always supposed to be below, below where the chest tube insertion is. So you never wanna, so if you have a patient on a stretcher or their bed, you shouldn't wanna you don't wanna have the box, like on the bed with the patient, especially like if they're recumbent or supine. It's
that's
usually
good.
gonna be lower, hanging down lower than where the actual insertion is, alright? So you wanna be careful with these tubes, because again, you don't wanna inadvertently pull out these chest tubes from the patient. Usually an individual that has a chest tube, usually it's just on one side, but sometimes there's pathologies and it's impacting both lungs or both sides, and they might have to have two chest tubes put in on both sides, so. Alright, so really quick, with immobilization, remember you wanna be careful with that term restraint, okay? Cause we are not allowed to restrain anybody or put restraints on anyone. In our field, we immobilize, okay? Now, the patient may have orders to be restrained, and that is going to be a physician, coming from a doctor. You have to have a doctor order in order to use restraints. So if you see a patient coming down to you on restraints, or you're doing a portable and they have restraints on either their wrists or their legs, you might have to untie them for the exam in order to get the receptor behind them, but just make sure you tie back the restraint and there's a proper way of tying it. You don't want to put it in a full knot. It should be a quick release type of securing that you're doing with those individuals. So when patients come to us, we immobilize them if needed, okay? Either for them to maintain the position we need them to, so sometimes we use tape a lot to help immobilize. With pediatrics, there's a lot of different tools, Velcro straps, different types of equipment that we could use with the pediatric population, but we do not restrain patients. We only immobilize them because it's a temporary type of thing that we're doing with them in order to obtain those x-rays. Or even when you go to CT, MRI, they usually have big Velcro straps that they can secure the patient and immobilize them to prevent them from moving while they are having their exam done. So the importance of history taking. We know our patients get tired of us asking them all of these set of questions, but it's important to document and obtain appropriate, accurate information regarding the patient history. And you want to ask the patient a lot of, remember we talked about asking a lot of open-ended questions, okay? Don't give the information to the patient. Don't say, oh, I see you're here because you're having abdomen pain. Ask the patient, why are you here? What brings you in today?
I love when they
All
say,
right.
I don't know.
Let them tell you what's going on. Yeah, you might get that too, I don't know, so you might need to do a little bit more further research, or tell them, well, I have ordered here for an abdomen x-ray. Are you having any issues in your tummy? Tell me what's going on. So ask a lot of open-ended questions and make sure you're documenting appropriately so you can relay that information to the radiologist, okay? Whether you're physically documenting on the form or you're entering it electronically. What if you're documenting something and you make an error? What's the appropriate way to deal with an error, like if you wrote something incorrectly?
A line through it, initial.
Correct. So you're going to draw one line through, initial it, and then write what you intended to write, or write what that correction was. What are the acceptable color inks for writing in?
Black and blue.
So black or blue. So you don't want to write in red or purple or neon pink. Make sure you always have a black or blue pen that you're able to write in. All right. So vital signs. What are our vital signs?
Blood pressure.
Temperature, rest, pulse.
All right, so I think you got all of them. Oh yeah, you guys said pulse too. So here are all our vital signs. So remember we had the whole lab on you guys taking vitals on one another. That's not something that's done on a regular basis in our profession, unless maybe you're at Concentra. Concentra, by the way, needs techs. I know it's not they are in desperation for techs. But
What's that? They probably don't pay much. Which one? What slide number?
It's 67. So that's not something that we typically do on a regular basis. Again, depending on where you decide to work, you may do it more often. Like if maybe you're at a doctor's office or an orthopedic office, they may have you doing multi-roles. Or like I mentioned at Concentra. But you want to be familiar with the vital signs, and I don't have it in this presentation, but make sure you go back in your textbook and look at the breakdown of what the ranges are. So remember with blood pressure, we have our systolic and diastolic. You wanna know what the normal ranges are for those areas. Same thing with the heart rate, respiration rate. They break it down for pediatrics and adults, along with the temperature. With temperature, you wanna be familiar with the different routes or ways that you can take the temperature. Okay, because remember we talked about rectal, oral, tympanic, so you wanna be familiar with all the different ways in which you can take a temperature. And then also the pulse oximeter, which measures the amount of oxygen in your blood. All right? So, on the registry, obviously you're not gonna have to demonstrate taking vitals, all right? But there's more than likely gonna be questions on there pertaining to vitals, okay? What's the normal rate or the normal range for someone's blood pressure? What is systolic measuring? What is diastolic measuring? If I'm taking someone's temperature rectally, which way does that entail? I'm gonna give you different multiple choice options. So those are the type of things that you want to be familiar with. Also the terms for areas that are out of the normal limits or out of the normal range. What does hypotension mean? Hypertension mean? Bradycardia, tachycardia, all of those little terms that correlate with vitals. Go back and look at that information. All right. So cardiac emergency. So I know you guys are asking about CPR, but we did spend some time on going over emergencies with patients and what you should do in CPR. So you're not necessarily going to have specific CPR related questions on your registry, but they are going to ask you some of the things that I'm talking about here coming up. So myocardial infarction, you want to know what that entails. You want to know, basically a myocardial infarction is a heart attack. All right, so if they ask you something about myocardial infarction and they have an option there on something related to the brain or something related to the urinary system, you know this is pertaining to the heart. It's a heart attack, all right? So it can lead to cardiac arrest, which basically the patient is not going to be having a pulse, and that's where we typically will initiate CPR. What's the first step in CPR?
Check for a pulse.
Right, so you want to approach the scene, make sure the scene is safe, and then you're going to check for responsiveness. Remember, hey, are you okay? Check while you're checking for responsiveness. You're checking the pulse, and then call for help.
Shout out for help and get an AED.
Mm-hmm.
And then listen to nurses.
So after you call for help or 911, or if you're in a hospital, you press the code blue button, then what do?
You listen for the breath.
Well, you already did that.
Okay,
You're checking for pulse while you're looking for responsiveness. So you're going to begin.
Glove up, what you call it?
So you're going to begin CPR, but what are you going to do first?
The chest.
So you're going to do
Chest
compression.
compressions.
Goodness.
But
How
you
much?
didn't say if you had a pulse or not, so I'm not gonna check if they had a pulse.
Right. Okay. So they have no pulse. So how many compressions are we doing? 30 compressions, and then what?
2 breaths.
2 breaths. And how many times are we doing that cycle?
You keep for about 2 minutes.
So for about 2 minutes or 5 cycles. And then what are you going to do?
Check again.
You're going to
Pulse,
check for pulse again, and hopefully by that point the AED or you've got the emergency team there where they're going to start putting the panels on. Why is it important to get the AED there?
Because it could read the pulse and stuff, and if it's not, it'll like she said, it'll shock you. You get
Yes.
shocked.
Right. So there's when there's a cardiac emergencies, there's various types of rhythms that the heart can go into. all right? And some of these rhythms, the only way to get the patient out of that rhythm is by that electric shock with the AED. So that's why it's so critical and vital to get that there, because you could be doing CPR all day long, and if that patient doesn't get that electric shock, they're still gonna be in that rhythm, all right? So these are the various types of rhythms that are associated with cardiac. So you wanna get that AED coming as soon as you can. And a lot of times, if you're in a public setting, the defibrillator, okay, is there. We've got one right down the hall. They're in most large entities, grocery stores, they're everywhere. All right, so it's pretty accessible to the public, to where if you still call 911 and while you're waiting, you can see if that area has an AED that you could go ahead and grab and start to operate on that individual and place the pads and turn it on and things like that. Remember with the AED, they're all different, okay, especially the portable ones or the ones that are in the public setting. So typically, when you open the AED, some of them automatically turn on, some of them you actually have to physically turn on. So be mindful of that, because you don't want to place the pads on the patient, and then you're like, nothing's happening, it's not talking to me, what's going on? You might have just simply didn't turn it on. Okay, so be careful and make sure that you're turning it on. What is this? What is this that we're looking at here?
EKG.
So this is an EKG. So this is, I just want you guys to be familiar with it. It's not in our scope of practice to do this. I mean, we have patients that come to us and they have those EKG leads on. Usually there's like 5 little stickies on their chest, and they're always in the way of our chest x-rays. But it's not in our scope of practice to do this or learn how to take an EKG. But I just want you to be familiar with this. Is a little pink slip that registers and monitors the heart rhythms, all right? And pretty much this is read by the physician to determine if there's any issues with the patient, such as fibrillation like you're seeing on the bottom, or tachycardia, or any other abnormalities going on with the patient's heart. All right, so let's switch gears to the cerebral area now for issues that might occur with the brain, all right? So we have TBI, which is traumatic brain injuries. So a lot of brain-related injuries isn't things that are open or that we're easily gonna see. It's not necessarily from a laceration. A lot of things are closed head traumas, and they result in the following areas that you're seeing here, such as concussions, contusions, or hematomas. Now, a lot of time with brain injuries, as we were talking about like the head regional or competencies, a lot of times those individuals aren't going to come to us for x-rays. They are going to go to CAT scan, all right? Because they're gonna be able to get a further, better diagnostic reading on the brain in CT. But you do wanna be mindful of what these different areas pertain and what they mean, because it may impact the individual being able to speak with you if they have a brain injury. They might be unconscious, they may not be fully competent, they may be confused, okay? So that's important to know with these various types of brain injuries. Also, you want to be careful with moving them or having them stand up. If a patient has a large hematoma, what's a hematoma?
Blood.
So, yeah.
A blood
So
tumor.
there's gonna be basically a bleed in the brain, okay? That might impact their ability to function properly, and you don't want a patient dropping on you. So, again, be aware of these individuals, because they may not be their normal true selves, depending on what type of injury they have sustained. Most traumatic brain injuries, they're going to do what's called the Glasgow Coma Scale, and depending on how they score in these different categories, they're gonna rate them on the scale, all right, and give them a number. So that's pretty much done in the ER. We don't do that. We don't have any involvement in that. But you just wanna know that the lower that total number, they're the more severe that injury is. So you want patients to have a higher number, because that means that they don't have as much brain injury. All right, we also talked about, various types of shock, right? So there's several different types of shock that a patient can go into. And again, these are all defined throughout your textbook. I can't remember offhand what chapter it's in, but they are all listed individual, as well as the definitions that you're seeing here. I think there's 9 main ones. So here we've got hypovolemic, septic, and neurogenic shock, okay? So you wanna know the definitions and what they can entail. That's actually a repeat. So you wanna be able to determine the differences between those shocks. So it's actually 6 of them. Here's the other remaining 3, psychologic, cardiogenic, and anaphylactic. So you wanna be able to understand the various types of shock because you might have like a situational question. You may have a question that the patient came to you for a intravenous pyelogram. The patient was administered contrast media. The patient was in full conversation with you, and when you went to check on the patient, they were totally unresponsive and didn't have a pulse. So they might say, what type of shock might this patient have gone through, or what shock do you suspect the patient having?
86.
And they'll have 4 of them listed, so what would you think the likelihood would be? No, it's actually gonna be anaphylactic, because they might have had an allergic reaction to the contrast media that was administered. So cardiogenic is just gonna be something directly involving that cardiac system. But because we administered contrast media to that patient, more than likely they had an allergic reaction. And we're gonna kind of talk about the anaphylactic when we get into the procedures a little bit, because remember there's different signs and symptoms. Some of them are going to be normal, some of them are going to be abnormal, so you want to be able to recognize the differences between those two when it pertains to contrast media. But that is the most common reaction or shock that we will see in regards to contrast media is that anaphylactic reaction. All right, so that's where getting your history is going to be important with your patients, because all of that can give you insight into, oh, should I be administering this type of contrast as opposed to another type of contrast? Should this patient be pre-medicated before this type of contrast is administered? So that is all within our role of questioning the patient so we can make sure they're as safe as possible. We also have insulin shock, all right, so this is involving our diabetic population, so you want to be careful with those, because especially with some of our contrast media exams, we have the patient's MPO that you're seeing up here. So what's MPO?
Nothing by mouth.
So nothing by mouth, all right? They're purposely kept that way, usually midnight before the exam. So with our diabetic population, you want to be keep that in mind, because that means that patient hasn't eaten, okay? So that could send them potentially into a type of insulin shock, all right? So you've got 2 variations when it pertains to diabetes. You've got hypoglycemia and hyperglycemia, okay? So hyper is too much sugar in their system, hypo is too little, and you've got the various symptoms that you may see occurring with these individuals. So you definitely don't want to ignore that, because it can lead to a severe outcome with our diabetic patients. And also communicate with the patient's nurse. All right, if you see these individuals, they're starting to exhibit any one of these symptoms, you want to communicate with that nurse, because they may need to come down and administer a certain medication. They might need to give them insulin. They may need to give them something to eat or drink, or advise you to do the same. So you want to be in regular communication. What does syncope mean?
Fainting.
Correct. So syncope, so sometimes, depending on what type of shock these individuals might be going through, you might encounter an individual that has syncope, or they could have it or exhibit sometimes a syncope just from not eating, okay? They may not have had anything, although we typically will advise patients to be NPO midnight before. Some patients may not have eaten the whole day, plus they're, now not having breakfast or anything. So you wanna be mindful of that as well. Especially if they're standing up, because you don't want that individual to get injured. What about vertigo? What's that?
Dizziness.
So dizziness, okay? So it's, and from what I hear, thank God I've never experienced this, but from what I hear, it varies on its severity. So some people have a mild form of it, some are very severe. So you just wanna be cautious of those individuals that are experiencing this. You definitely don't want them standing up. We all know that every patient that comes to the ER for the most part is gonna have a chest x-ray. Even if they got bit by a mosquito, they're getting a chest x-ray. So these individuals also are gonna probably have a chest x-ray ordered, so you just wanna be mindful of that, because you don't want them to stand up and then potentially fall. All right? What about dehiscence?
Say it.
I'm sorry. Dehiscence.
Could you spell it?
Dehiscence.
Like liquid comes out like the blisters. Oh, no, that's when it's.
So it's an opening of a suture wound. Dehiscence. So that's where a patient may have had recent surgery, and the suture site is starting to open. So you want to be careful. A lot of surgeries that are performed nowadays, they do try to minimally invasive, or they're doing it laparoscopically. But you do have like some emergent surgeries where they're going to have to open up, the patient. C-sections are still opening up. So you just want to be careful with those individuals, especially anybody that's coming in saying they have abdomen pain. I usually will ask them, oh, have you had recent surgery? Because they, like you said, patients aren't always very verbal with you. So you have to pull those questions out. So you just want to be cautious with moving individuals and stuff like that if they've had a recent surgical site or sutures. What about patients? What type of injury is this?
Ooh, trauma.
So trauma.
Look like the hip is because of the foot. Pelvis. Yeah, because of the foot to the side.
So would that be more of a pelvis or a hip?
Hip.
Or hip.
Hip.
Let's
Hip.
say hip.
It's externally rotated.
So
Yeah.
that's gonna be your hip. Okay, so not so much the pelvis, but your hip. Remember all of your terms. I don't think we're gonna really touch on this here, but remember all of your terms as far as proximal, distal, anterior, posterior. Remember the differences between your position versus your patient, your projection. Okay, those are two different things. So go back and review that. But yes, this is a trauma patient. More than likely they have a hip fracture. That's why we're seeing that external positioning of their lower leg. If this was a fracture, what type of fracture would that be termed?
Open.
Compound
Because the
fracture.
skin broke.
Because that fracture broke through the skin, so that's termed a compound fracture. So remember, we encounter all different types of patient scenarios, so that's why our field utilizes critical thinking. We have to think on our feet for all these different types of patients that we're going to encounter, because we never know. All right, how would you get a AP on this individual?
How many what?
So ideally, you're probably going to have to do a cross table, because they're already in a lateral position because of their injury. All right. So with extremities, with trauma patients, you always want to have two views 90 degrees of one another. That's kind of the rule of thumb. And we, with our x-ray equipment, might have to maneuver that x-ray around the patient because they're not going to be able to move. all right? And get help, okay? If you need help, make sure you get a peer technologist if one's available. Or once you guys are out in the field, grab that student, all right? You guys are gonna be working. Y'all have finished your program, you're a registered RT, so you better grab that student and be like, oh, come with me, this is a trauma patient, I need you, all right? Just don't have them hold the receptor or hold the patient. So use your help. Okay, we're gonna end there. So we're pretty much halfway through the presentation. Again, I'm not gonna hit on every single slide that's in here, because some things are just repetitive and some things are a little bit elaborating on, pretty straightforward stuff. But next week, when we come back, next week Tuesday, we'll pick up with slide 102. And we're gonna spend time talking about renal function, some of the labs, the importance of lab work, some of the common labs that we look at for our fluoro exams and why we need to look at them. So we'll spend time talking about that. We'll talk about contrast media, the different routes of administering contrast media. We'll spend a little time about venipuncture, and we will talk about various types of infections, bacteria versus viruses, patient being on isolation protocols. There are different types of isolations that they are on, and we'll end with a recap of like sterile gowns, sterile gloves, sterile environment. So that's what we'll be doing next week. All right. Let me just go, before you guys run out of here, let me just go pop in with Ms. Wallace, make sure she doesn't need anything from you guys before y'all are dismissed.